I'm Harriette Van Spall, Associate Professor of Medicine at McMaster University, and I'm honored today to have Dr. Kosiborod, who is a Professor of Medicine at the Mid-America Heart Institute, and we are here to discuss the DAPA-HF results pertaining to quality of life. Thank you for being here.
My pleasure. Thank you.
So DAPA-HF has been one of the groundbreaking clinical trials of the year. And its primary endpoints were very impactful in the care of patients with heart failure and reduced ejection fraction. The primary outcome was presented at ESC, and we are here to discuss your findings at AHA as they pertained to patient-important measures.
Right.
Why don't you tell us about your analysis and your findings?
Well, thank you, Harriet. I think what's important to keep in mind is if you kind of think about what are the goals of management in heart failure for our patients, heart failure in general and certainly heart failure with reduced ejection fraction, I would say there are kind of two overarching objectives. One is to reduce deaths and hospitalizations, and the second is to improve health status, which includes symptom burden, physical limitations, and quality of life. And actually that reflects how we designed the DAPA-HF trial, because the primary objective of DAPA-HF was to examine whether dapagliflozin would reduce deaths and hospitalizations. But a key secondary objective was to actually look at patients' health status as measured by the Kansas City Cardiomyopathy Questionnaire, or KCCQ for short. And so, of course, as you said, the primary results were presented at ESC. There were some additional other analyses were presented here at American Heart, and one of them included the specific secondary objective, kind of really dissecting in detail what it looks like for patients treated with dapagliflozin or placebo when it pertains to health status.
And so tell us a little bit about your methodology and your findings and how they impact clinical care.
Right. So we really wanted to understand three things. One was to try to really rigorously evaluate whether there would be any difference in the clinical effectiveness of dapagliflozin in reducing clinical endpoints, including primary, which is CV death or hospitalization for heart failure, urgent heart failure visits, or a number of additional clinical endpoints, such as separately heart failure hospitalizations, CV death, all-cause mortality, and whether that would vary, so whether that effectiveness in lowering the risk of clinical endpoints would vary based on symptomatic impairment and baseline. And so we divided patients into three tertiles based on how impaired their health status was, as measured by KCCQ total symptom score. So essentially severe, moderate, and mild impairment and symptoms at baseline. And we tried to understand whether there was any difference in a relative risk reduction with dapagliflozin versus placebo in those clinical endpoints. And what we found in that regard was that dapagliflozin was equally effective, or effective to a very similar extent, regardless of whether patients had mild, moderate, or severe symptomatic impairment. There was absolutely no evidence of heterogeneity of treatment effect, essentially indicating that whether your patients have severe burden of symptoms, moderate or mild burden of symptoms, they benefit equally or to a similar extent with dapagliflozin as compared with placebo. The second and third objectives really had to do to then look at how dapagliflozin affects the health status itself. And we measured mean differences between treatment groups over time, and we also did what's called the responder analysis. In the responder analysis, you essentially look at a proportion of patients that have a clinically meaningful deterioration in symptoms, as well as health status overall, and then a proportion of patients that have small, moderate, and large improvement in health status with dapagliflozin versus placebo. So what we found in that regard was that patients treated with dapagliflozin had a greater improvement in their symptoms, function, and quality of life over time. That effect was already evident at 4 months and was somewhat amplified at 8 months. And that was true for both the symptoms as well as other components of health status within KCCQ clinical and overall summary scores. In a responder analysis, what we found was very consistent with that, which is greater proportion of patients treated with dapagliflozin had small, moderate, and large improvements in health status. And smaller proportion of patients treated with dapagliflozin as compared with placebo had worsening of their total symptom burden, functional status, and quality of life. And the numbers needed to treat for that benefit in symptoms and other measures of health status was very small. It was ranging between 12 and 18 at 8 months. So I think that's probably the most kind of a critically important from a clinical standpoint take-home.
Absolutely.
Kind of key takeaway is that the number needed to treat to actually have symptomatic improvement with dapagliflozin versus placebo was relatively small.
Absolutely. It's interesting how we have changed the way we design clinical trials now to incorporate measures that are most important to patients. For patients who have advanced stages of heart failure and who are symptomatic, many of our primary endpoints still focus on CV death and heart failure hospitalization. And I find through my work that when patients weigh in on the study design, they often value health status and quality of life and functional capacity over survival time.
Right.
And so it's a wonderful move forward for science that these measures are now being incorporated, whether as secondary endpoints or exploratory endpoints, but that we're able to know the effect of our therapies on the symptom burden,
right,
and offer therapies in a meaningful way to patients.
Yeah, no, I think it's critically important because, as you pointed out, Harriet, there are some patients who would actually even trade improvement in the quality
That's
of
right.
life for reduction in survival. Now, of course, here we don't have to trade anything. We
Right.
have,
It's a win-win.
better survival, better lower rate of hospitalizations, and patients feel better. So it's really, 3 for 3 here. But as we go forward, actually, these patient-reported outcome measures are becoming increasingly important. They're actually recognized now in the guidelines, many of the guidelines. Some of the governmental healthcare reimbursement bodies are paying much more attention to it. And perhaps what's also critically important is that the regulators, including U.S. Food and Drug Administration, are starting to recognize that these measures are critically important. In fact, if you look at the draft FDA guidance for heart failure trials, it's actually now at least being proposed as one of the approvable and important endpoints.
Absolutely. I think dapagliflozin is a winning therapy because it significantly improved the primary endpoint of CV death and heart failure hospitalization, and as you point out today, improved quality of life and health status in patients. And you've also demonstrated that patients derived benefit regardless of their baseline health status. Thank you so much for joining us and for weighing in on how we might use this therapy in patients with heart failure.
It's my pleasure. Thanks for having me.